Good afternoon to all. I am Dr. Ankita Tibdewal, Senior Resident in the Department of Cardiology at SSKM Hospital. I am presenting a case of a 21-year-old male patient. He presented to us with the history of gradually progressive breathlessness on exertion since 3 years of age and intermittent hemoptysis since the age of 10 years. He was evaluated in multiple places. At the age of 10 years, he got a CT scan done which showed a suspicious tuberculoma, for which he was prescribed anti-tubercular drugs for a full course of 6 months. However, there was no resolution of symptoms of the patient. In fact, 2 years prior to presenting to us, the patient had worsening of his symptoms. Elsewhere, he was evaluated and diagnosed to have idiopathic severe pulmonary arterial hypertension. On examination, the patient had all stable vital parameters. His jugular venous pressure was not raised. His SpO2 was 93% under room air in all the 4 limbs. There was conjunctival suffusion, but no cyanosis. There was no pedal edema, and grade 1 clubbing was seen. On clinical examination, his apex was in the left 5th intercostal space in the mid-clavicular line, diffuse RV kind of apex. Grade 1 parasternal heave was present. Patient had palpable P2, a single loud S2, and a grade 3 pansystolic murmur in the left lower sternal border, suggestive of tricuspid regurgitation. The positive findings on his blood investigations included polycythemia, microcytic hypochromic RBCs, reduced serum ferritin, raised uric acid, and raised NT-proBNP. His chest X-ray showed an enlarged RA shadow, an RV kind of apex, and oligemic lung fields. His initial echo that we did on presentation showed similar features that was already diagnosed for the patient, and we were not able to diagnose anything extra. It just showed, what we saw was RA-RV dilated with normal RV systolic function, severe TR, and features of severe PH. We were not able to diagnose anything extra at that point. We took the patient for CAT study. When we started doing the CAT study, it was late night at 11 p.m. and we were all very tired. However, we had taken up the case as we had been deferring this case for a long time. So we took the catheter from the IVC, the catheter went to the RA, RV, the MPA and the LPA. We were not able to enter into the RPA. However, we was repeatedly seeing that the catheter was entering into the descending thoracic aorta. So we started suspecting that there was a PDA that we had missed on echo. The pressures were also suprasystemic. In the RV, it was 158 RVSP, and the PASP was 160 with the mean pulmonary artery pressure of 75. The similar suprasystemic pressures were found in the left pulmonary artery. On further contemplation, we decided to take an LV angiogram. When we took the LV angiogram and aortogram, we saw that the right pulmonary artery was arising from the aorta, and the pressures in the aorta and the right pulmonary artery was similar, which was around 130. The calculated PVR for this patient was 35 Wood units, and the PCWP was 12. This is the image showing the RV angiogram of the patient. We can see that the catheter is in the trabeculated right ventricle, which is giving rise to the main pulmonary artery and the left pulmonary artery. We cannot visualize the right pulmonary artery on the angiogram. And the PDA is arising from the left pulmonary artery and into the DTA. So this was the course that the catheter was taking during initial pressure study. We took an LV angiogram and we could see that the right pulmonary artery was arising from the ascending aorta, and it was a left-sided aortic arch. We further went for a cardiac MRI for this patient, which confirmed our suspicion of an anomalous right pulmonary artery arising from the ascending aorta, and the LPA was arising normally from the main pulmonary artery.